Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Welcome to Conversations with CEI. My name is Lauren Walker, and I'm the Program Director for CEI's Hepatitis C and Drug User Health Center of Excellence. On today's episode, we'll hear from Dr. Sharon Stancliff and Dr. Jennifer Love about emerging substances in the New York State drug supply, including an update on Xylazine. New York drug overdose deaths and death rates are on the decline, but with significant disparities, and the current toxic drug supply is partially to blame. Harmful additives like fentanyl analogues, Xylazine, and Medetomidine, among others, have been found in cocaine, heroin, MDMA, and pressed into pills. Additives are undetectable by sight, taste, and smell, which increases the risk of overdose for people who use and may not be aware of what's in their drug supply. The New York State Department of Health Drug Checking Program offers people who use drugs timely and detailed information on the contents of their substances. It also shares information on the state's unregulated drug supply to inform clinical care, advocacy, research, and policy. The program has tested over 2,000 drug samples, and findings indicate a steady proportion of Xylazine in the drug supply, as well as a recent increase in the percent of samples containing Medetomidine, a novel, powerful sedative that we'll discuss today. I'm honored to introduce my two guests who will help unpack all of this and share best practices for New York State-based clinicians to support people who use drugs. Our first guest, Dr. Jennifer Love, is an assistant professor of emergency medicine at the Icahn School of Medicine at Mount Sinai. Her research interests focus on improving emergency department care for people who use drugs, and she is currently working on studies related to Xylazine adulterated fentanyl. I'm also joined today by Dr. Sharon Stancliff, Associate Medical Director for Harm Reduction in Healthcare at the New York State Department of Health AIDS Institute, and an attending physician at Project Renewal, where she provides care for people with opioid use disorder. Dr. Stancliff has been working with people who use drugs since 1990, including the development of overdose prevention programs, provision of primary care for people who use drugs, substance use disorder treatment, HIV care, and harm reduction services. We are lucky to have you both with us. Welcome to the show, everyone. How is your day going today?
Pretty well so far.
So far, so good. Well, thank you again for joining me. Given that today's episode is a follow-up to one that you and I did together, Dr. Stancliff, in February 2023, could you kick us off with just a brief reminder about some of the adulterants that we commonly find in the New York drug supply? What do they look like? Do they have a taste or smell?
Well, some of the most common ones right now are Xylazine and, of course, fentanyl and its various analogues. And the one I always stumble over, Medetomidine. So these are showing up a lot in what we're seeing. Fentanyl and its many analogues are synthetic opioids. They're found basically in everything that is sold as heroin. It's also found in counterfeit pills, rarely, but occasionally in stimulants, which of course can be a catastrophe when that happens. There's a lot of analogs out there, at least 80 of them reported to the United Nations. Not all are illegal because they just haven't been looked at and scheduled, but there are laws that may change that. Xylazine and Medetomidine are also found. These are alpha-2 adrenergic agonists. They're used basically in veterinary medicine as sedatives, painkillers, anesthetics, and they are not approved of for human use. Both of them cause extreme sedation, hypotension, and bradycardia. The Medetomidine is a newer addition. There's a lot we don't really know about it yet, but it is clearly more potent and has a longer duration of action than does Xylazine. Now, folks may know that Xylazine has been associated with severe skin wounds, not related to the injection necessarily. We don't know yet about Medetomidine, unless maybe Dr. Love has some new information, but we haven't seen enough of it to know that for sure. Can you tell by looking at your drugs these are in there? No. People say a lot of things about it, but you can't tell by looking or any odors. So there's only a few ways to find out if it's in there. And we'll touch a little bit on drug checking, and we have test strips for both Xylazine and fentanyl that are widely available.
That's a great question, Sharon, that you posed about Medetomidine and its relationship to the wounds. I think, like you said, there's really a lot that we don't know about Medetomidine. The little that we do know from the veterinary literature suggests that there is some peripheral vasoconstriction in animals that receive this. So there could be a role that it may be involved in some wound development, but we just don't have enough data yet to really understand the mechanisms of xylazine wounds, let alone if there's a role of medetomidine there. I think the other important thing that we're starting to understand from the veterinary literature about medetomidine is that in conjunction with opioids, like as you mentioned, as given as an anesthetic in animals, it can cause severe respiratory depression. And so sort of as it continues to emerge as an adulterant in the opioid supply, we may see some of that clinical effect in our patients.
Thanks so much. Dr. Love, I'm curious, are there other emerging substances in the state supply that you've identified in your research as a toxicologist that folks should know about?
Yeah, I think there's two important ones to bring up. Dr. Stancliff referenced the fentanyl analogues and sort of the growth of fentanyl analogues and how they're always evolving. Nitazines are also a novel synthetic opioid that have been linked to opioid overdose fatalities in different areas of the United States. Some ones that people may have heard about are isonitazine or protonitazine. They are more potent than fentanyl and heroin and some of our other opioids. They are reversed by naloxone. We do know that naloxone works to reverse the effects of them in overdose. However, patients may require more doses of naloxone, but that is one group that is sort of out there among the drug supply. The other adulterant that is emerging is something called BTMPS. It's one that has been detected in different pockets of the drug supply. The first location I believe it was detected was in Portland, Oregon. And we've seen it in places such as California, some areas of the Midwest, and then in New York as well. We don't know a lot about it. It actually was developed as a light stabilizing agent and was used for manufacturing and packaging of pharmaceutical agents. But now we've seen it sort of commingled with some of our opioids. It does, again, we're starting to look at animal models and how it has clinical effects in animal models like rats and mice in the lab where researchers are doing experiments. And we're starting to see like what receptors it might bind to and then try to understand what clinical effects it could have. But that data is all very, very new. And so we really don't have any ideas about what it potentially could be causing, if anything, in humans.
If I could just put in a quick word about naloxone, I wanted to mention under fentanyl that, as Dr. Love just said, naloxone works fine with fentanyl. And in fact, when we look at the carefully done studies, we're not seeing an increase in the number of doses needed. I can't speak to nitazine, which is much more rare, but we do see from work in New York and in Pittsburgh that the number of doses, if looked at appropriately, has just not gone up over time despite the ubiquitousness of fentanyl. People may look still very sedated with the other drugs on board, but if they're breathing, they're good.
So, Dr. Stancliff, kind of a side question here, you just made me wonder. What would happen then if someone is experiencing an overdose with some of these other substances? Main substance might be opioids, and they are given naloxone. What would happen, and what would you encourage someone to do if they encounter someone who is experiencing an overdose?
Well, if you are with somebody and you know what they're using and they go down, then certainly put your naloxone if they're not alert. Rescue breathing or even chest compressions are a good thing to do if they're not breathing. Try to wait 2 minutes. And it's scary. I've done this. It's scary to wait 2 minutes and give more naloxone if they're not breathing. But if they start to be a little bit responsive, we don't need them to wake up. We just need them to breathe and preferably call EMS for more help. But they may still be very sedated. And also, no matter what else you're going to do, open their airway. If somebody's slumped and doesn't have a very good respiratory drive, even if the respiratory drive is there, they may not be able to get the oxygen in.
So just one additional point about naloxone. I think a really important epidemiologic trend that we're seeing with all of these new substances, xylazine, medetomidine, BTMPS, is that they're all in the presence of an opioid, which is largely fentanyl right now. We're not seeing really any of these in isolation. People are not accessing them and using them in isolation and overdosing on them in isolation. They're really always co-located with fentanyl. And so in that situation, as Dr. Stancliff said, naloxone will work. It will save the person's life because you are largely reversing the effect of the opioid. And that's most of what somebody is being exposed to. And the adulterant is having additional side effects, but the thing that will be life-saving for them is receiving the naloxone.
Thanks, Jennifer. I want to pause here for just a minute, if I can, to give our audience a brief introduction to the New York State Department of Health drug checking program and the two services that they offer. Before I dive into details, it's really important to point out that the program is not affiliated with law enforcement, nor is it ever used for any punitive action. So the program allows individuals to have their drugs analyzed to identify the composition of the substance or substances they're intending to take or have already taken. Here in New York, we have community drug checking through point-of-care mass spectrometry technology at 6 drug user health hubs across the state. We also have RADAR, that stands for Rapid Drug Analysis and Research, which involves partnerships with local health departments and others to support mail-based drug checking. New York City also has its own program, and I won't get into too much here, except to say that it was the first of its kind in the United States, and it served as a rough guide for the statewide drug checking efforts that we have today. They developed a wonderful toolkit. It's called Setting Up a Drug Checking Program, a comprehensive guide that I highly, highly recommend for programs interested in setting up drug checking. That's linked in the resources for this podcast. We'll get back to all of that in just a minute, but I want to bring the conversation back to the clinical aspects of these additives first. So, Jennifer, we know that xylazine is approved only for use in veterinary medicine, and I'm wondering, what about the other substances we've been talking about today? Do any of them have clinical purposes beyond animal medicine?
Yeah, so as of right now, all of these are restricted to veterinary use for xylazine and medetomidine. Xylazine and medetomidine, as Dr. Stancliff pointed out, they are within a drug class called alpha-2 adrenergic agonists. And so we have some medications that are approved for human use that fall within that class. And that's sort of how we try to understand the effects that these adulterants might have. Those 2 drugs are clonidine, which is an antihypertensive medication that a lot of people may be prescribed or prescribe in their practice. The other one is something called dexmedetomidine, which is an anesthetic used largely in the ICU, sometimes in the emergency department for patients needing anesthesia. But xylazine and medetomidine themselves are still restricted to veterinary use. Analogues, the nitazines, BTMPS, those are all very, very new, again, have really no human use, aren't really having any known sort of veterinary use either, to my knowledge, but are sort of just evolved in a chemical way that they are becoming more available in the opioid supply.
So as you're seeing some of these substances more regularly in the supply in New York, how are you applying drug checking in clinical practice, and what service is that providing to both you and the clients that you work with?
Yeah, I work in sort of 2 clinical environments. I work in the emergency department, and then I work in a small clinic that's co-located within a syringe exchange. And so they're very different clinical environments, but I would say that I incorporate their information and the resources of drug checking in both situations. In the emergency department, I think I do a lot of bedside education with patients to let them know post-overdose that drug checking is available for them. We also have kits that have naloxone available as well as test strips, and we hand them out to patients for free at the point of care in the ER. And that's for patients also who maybe haven't come in specifically for an overdose, but report substance use as part of their medical history, such that we're really trying to make drug checking, particularly with test strips, more available to people. And if their access point to healthcare is even in the ER. In the clinic, I would say we also provide test strips, but we also have the additional resource of having information through the New York City programs of the FTIR drug checking. Well, they will come on site and check samples that have either been collected or submitted and do it with test strips, but also do it with GC mass spectrometry. And so we're able to get more detailed data. And I think for me, working once a week in this clinic, I appreciate that data because then I can report it back to my patients and try to let people know sort of what's maybe available or in the supply in their local community. Because while my ER job is in Manhattan and my clinic job is in Brooklyn, those 2 supplies may be vastly different. And so I really appreciate having a wealth of resources for drug checking, largely so that I can impact patient education and really try and encourage people to engage in drug checking practices on their own to help keep them safe.
I also, besides working at the State Department of Health, work in a clinic once a week, and we hand out a lot of test strips there. Basically, all of my patients have opioid use disorder, and that's what I'm there for. And there's a lot of things I appreciate about the strips, but one of them is simply the way it opens up conversations. There's lots of ways to tell my patients that I still care about them if they still use other drugs. I hope they know that pretty clearly by now, but we really want them to know what they're getting. Early on, before fentanyl was ubiquitous, we added it to our urine drug tests, not as a gotcha item, but so we could tell people that they were getting fentanyl. We don't make big decisions usually most of the time on urine drug testing. Now I can give them the tool that they can take out into the field. They can give them to their friends. And it just I think it shows a huge amount of respect for people to help them understand that they can make some choices about what they're getting or what they might get the next day. And I really like the level of respect that gives. Also giving them naloxone kits. Not only it might save their life, but I think they can go out and save lives. So all these tools, I think, are good for them developing better senses of themselves, having been so stigmatized as drug users for a long time.
That's interesting. It sounds like drug checking, whether it's a mass spectrometry or just a test strip, it can almost act as a gateway to other services to build trust with the clients that you're working with and potentially have them return to care or return to you for other issues that they're having. What a wonderful full circle moment.
Certainly don't want patients to be coming in on, then to go see Dr. Stancliff that she's going to complain that I'm using drugs. No, we're going to see what's going on that's good.
So I'm sure we have some listeners out there very appreciative of this information, just understanding what substances are out there. But some also might want a little more in terms of actionable resources. Luckily, I think both of my guests today are poised to provide them. Jennifer, could you kick us off? What would you recommend to a listener looking for more information that they can use to take action either by themselves or in clinical practice?
That's a great question. I think that sort of in the spirit of discussing drug checking and drug checking resources, I think that the data that the New York State Department of Health provides online about drug checking, it's linked in the resources, is as real time as we can possibly get it right now in terms of letting people know what might be in the supply, what to look out for, and sort of making connections about some of these new things that they may have heard in other regions, and then affecting their clinical care and the care they provide to patients, no matter what sort of setting that's in, whether it's in an ER or a hospital or a clinic. I think that we, with this problem, need to try to be more proactive with our data and our response and less reactive, trying to remind ourselves to look at the data that's out there that our epidemiologists and our departments of public health are putting out and screening for sort of in a continuous way is really the most proactive that we can be at this time.
And I also want to let people know that whether they're in a clinic or they're an individual at home, they can go to Matters, which is a Buffalo program, which will supply them with fentanyl test strips, xylazine test strips, and of course, everybody that's at risk of seeing an overdose should be carrying their naloxone. I've used mine 3 times on the streets of New York, all 3 times. It actually was an overdose because they came around. So those are things that people can do right now without having to make institutional changes. Institutional changes are possible, but they take some time.
Thanks for that. In addition to the Matters Network, folks in New York can also order naloxone and other supplies, both from NextDistro, their online distributor, provide for free these services, as well as Oasis. So all of those links, if you're interested in getting your naloxone, getting your test strips, getting anything else to make drug use safer, we do have several places where those are available here in New York. I want to switch gears a little bit and talk about the future. And I'm curious, both Dr. Stancliff and Dr. Love, what you think about the future if these programs were expanded statewide or potentially put into more than the 6 drug user health hubs that we have available. So what do you think the clinical impact would be? What would be the positive change?
Up until recently, one of the only places we've known what people were getting in their drugs is primarily from autopsies and a little bit from urine drug checking. That would be a different world if people could know what's in their drugs, like they can go to the pharmacy and look at the bottle of whatever the gas reliever is and find out what is actually in it. So that would be a big change. And I think that we would see people change behaviors. Now, everybody's not going to say, oh, there's fentanyl in here, unless it's cocaine, and not take it. And that's the thing that's a misunderstanding. But people make other kinds of changes, and we can get some concrete examples of that. choosing a different supplier might be something that they might do. Understanding what happened to themselves might be something. So a lot of times people check after they use and discover that they had a really strange experience and avoid that experience in the future. Again, I think that being able to refer more people to such places shows respect for the patients, which I think is a key part of all this. So I think, and as Dr. Love has said, we can do better education with our patients on what's out there locally rather than looking at data from Western New York when you're in New York City and vice versa.
Dr. Love, same question. What do you think will happen in New York State if drug checking is expanded and these services are available to everyone?
This is a dream that I sort of have, is like how to think about, when I put my research hat on, how to integrate the numerous data sources that sort of exist in separate pillars, but could be tremendously powerful if we were able to integrate them in real time. A lot of my research is focused around like the clinical effects of these novel substances. And so I personally pull data from resources like drug checking from laboratory colleagues, as well as like patient medical records. And those two data sources provide a lot of information. Then there are programs like the epidemiology programs throughout the city and the state, which do more surveillance and screening data, which can maybe get things in real time. There's data that exists from autopsies, right, and our fatal overdoses. There's data that I look at on social media where people, because they are able to be anonymous, will report in tremendous detail about their experiences or new drugs or new symptoms they're having. How could we possibly integrate all of this into a real-time type dashboard that myself as an ER doctor or somebody practicing an outpatient setting at the start of a clinic morning could access and look at and see sort of what is going on and really be able to talk to patients and empower patients, as Dr. Stancliff said, with this information. I think a lot about in the ER how much patients still don't want to be there, patients who use drugs, that they still feel a lot of stigma from the healthcare setting. And that is certainly still pervasive at times in the ER. And I wonder if we had data that ER clinicians could check in real time, if it would open up a conversation and make it easier to enter a conversation with someone at the bedside, that would then sort of convey to that person, I care about you. I want you to come to the hospital. I want to be able to provide you care. This is my job. This is what I'm here to do for you. And it might help ease up some of this stigma and the barriers that have been in place for people who use drugs accessing healthcare. It's really a goal that I would have in the future. And I do think sort of integration of data and empowering healthcare providers could then help empower patients and create more open doors to healthcare for people who use drugs.
Yeah, I'd just like to add a little bit to that. I found over the years that a lot of my medical colleagues
Are not comfortable not knowing things. And I think that adds to some of the distance, is not knowing much about what's out there on the street. And the more ways that we can help them understand that, I think it becomes easier for them to relate to their patients and listen to them.
Yeah, I very much agree. We spend so much time in medical school and residency learning about hypertension. So it's so easy to talk to somebody about their blood pressure or even their smoking habits, right? But this is such an evolving topic, and a topic that people may have not gotten a lot of recent training or information on. And so that information gap, sort of closing that for healthcare clinicians, I agree, might really help them connect with this patient population better.
In addition to kind of improving or tailoring clinical care for an individual or just empowering a clinician to know what they're talking about, do you think that there's room to improve public health messaging on a larger scale with this same data? Could that be used to kind of inform the public as well?
Absolutely. I mean, as I said early on, we were testing people's urine for fentanyl just so we could let folks know. But that is not a source of data that's particularly out there for the public to see. Now, anybody looks into what's going on with heroin on the street, which there is almost none of, or pills, they can learn, because we'll have the more data we've got about what's actually in the supply, the better off it is. Understanding that rare, but fentanyl can be found in cocaine at times. One of my patients gave test strips for fentanyl to his friend that had bought some cocaine, and that friend chose not to use it because it tested positive for fentanyl. So getting those words out there so that people know that maybe they want the scripts, that they know they want naloxone, they want these programs out there is key.
I feel like we're kind of wrapping up the conversation, and I really honestly hope that it has been intriguing to our listeners as it has been to me. I'd like to wrap things up today by asking each of you, Dr. Stancliff, Dr. Love, to share an example of a change that you've experienced or observed as a result of drug checking, or potentially better yet, a positive change that a client made after accessing services. Sharon, similar to what you said, folks don't always decide not to take the drug just because it has something in it. What are some other examples of how people that you work with are using this information to change their behavior and potentially stay safer?
Well, one of my patients a while back disclosed to me that he was selling amphetamines, gave him test strips, which he used, and he basically returned one of the supplies to a supplier saying, there's fentanyl in here. I can't sell this. I think that's huge. And I think there is the potential, not on a daily basis, not somebody that's just bought whatever dope they've got and they need to use it before they get dope sick, but on a broader scale, move the supply into a safer place. I don't want to leave out this part. I provide drug treatment to my patients with buprenorphine, but building those bridges to treatment, I think, is part of it as well. It's like, I'm scared. I really need to make some changes now because I know what's out there.
Well, and potentially building a bridge too, like you said, Dr. Love, to let someone know that you care, that you can be trusted, that you can be listened to when those scary moments do come up. Do you have a similar experience that you'd like to share with folks?
Yeah, I think sort of as Dr. Stancliff just mentioned, I think that encouraging the patients and clients that I work with to participate more in drug checking has moved some of them towards discussing treatment options because they are so concerned about the adulterants and the sort of continued evolution of adulterants in the supply. And not that we always want fear to be a motivating factor, but I think that additional information and some of the education based on the experiences of individuals in Philadelphia, where a lot of these adulterants have sort of been the first place, and we've seen some of the more severe clinical effects, has really moved people to engage with me to get them started on Suboxone. And so I think that has been just tremendously rewarding then to sort of see patients who are eager to learn about treatment options, eager to try treatment options, and just really protect themselves in a way that will prevent them from overdosing.
Well, thank you both so much. This has been a wonderful conversation. Is there anything else that you'd like our listeners to take home with them as a key message today?
Get your supplies and carry them and give them out as needed.
I would just encourage people to really talk about this, I think, as we've really said over and over again, and not just necessarily talk to your colleagues if you're a clinician or talk to your patients, but talk to your friends, talk to your family, who this could potentially affect. And so I think just the more we talk about this, the more we normalize it, and the less it stays stigmatized, and the more that we can affect positive change going forward.
Well, thank you again for joining me today. I hope you both have a wonderful rest of your afternoon.
Thank you for having us.
Thank you.
Right. All drugs carry some level of inherent danger. However, risk increases exponentially with an unregulated supply. Drugs in New York State vary by makeup and strength or potency, such that users are not always aware of what they're taking or how it will impact them. Drug checking provides information about what is in a substance, allowing users and clinicians alike to make better informed decisions. For example, referring clients to drug checking provides them with information and autonomy to make decisions about their use. At the same time, as a clinician, you can use drug checking data to inform clinical care and the recommendations you make for your patients. I hope you check out today's podcast resources to learn more, or give us a call if you have a related clinical question you'd like to discuss with one of our experts. We're toll-free at 1-866-637-2342. Just press 5 to speak with a clinician about drug user health.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.